You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Hello and welcome. You're listening to the ATS Breathe Easy podcast with me, your host, Dr. Eddie Qian, also the host of the ICU and podcast. Each Tuesday, the ATS will welcome guests who will share the latest news in pulmonary, critical care, and sleep medicine. Whether you're a patient, patient advocate, or healthcare professional, the ATS Breathe Easy podcast is for you. Joining me today, I've got two very special guests. Anna Podolanczuk, who's an assistant professor of medicine at New York Presbyterian and co-director of the ILD program, and then Joe Mammarappallil, who's an associate professor of radiology at Duke. Thank you guys both for coming.
Thanks for having us.
Absolutely. So today, our topic of conversation is going to be talking about ILAs, or interstitial lung abnormalities. I think, to start, this is a relatively new definition as far as like the history of medicine is concerned. Anna, can you help describe to me what is an ILA, just to set the stage?
Sure. So over the last decade or two, there's been increased awareness about trying to diagnose interstitial lung disease and pulmonary fibrosis earlier. And so there's been a number of research studies that have looked at subtle changes on a CT scan in individuals who don't have a known diagnosis of interstitial lung disease. And they had undergone CT scans for things like lung cancer screening, or they were enrolled in a research cohorts like Framingham Heart Study. And a number of studies have looked at their CT scans and found that quite a large number, actually, of individuals in those studies have changes that are suggestive of interstitial lung disease. So those are things like reticular abnormalities or ground glass opacities, and sometimes more advanced fibrotic changes like traction bronchiectasis or honeycombing. And so in 2020, the Fleischner Society formally defined the term interstitial lung abnormality, and then they defined them as those findings of reticulation, ground glass opacities, traction bronchiectasis, honeycombing, or architectural distortion that involved 5% or more of a lung zone. And in 2020, the Fleischner Society, they need to be found in individuals, they need to be incidental findings, so in individuals who don't have a known diagnosis of ILD. We recently updated that definition as part of a large committee and an ATS-sponsored document on interstitial lung abnormalities, and we largely retained the radiologic definition of ILAs, but we did remove that need for the incidental findings, and so allowing for ILAs to also be identified in screening population, like those undergoing lung cancer screening, or those with connective tissue disease, or those with a family history.
Yeah, no, that makes a lot of sense. And so much of this is dependent on a radiography because a lot of these patients don't have symptoms. Joe, what kind of things do you have to add as far as like the radiologic definition? And then also, can you give me a little bit of your experience on what you're seeing as a thoracic radiology?
Yeah, I would love to. We've learned a lot about fibrotic lung disease over the last 10 years. Honestly, we didn't really know anything too specific before 2013. The medications really forced us to get really good at diagnosing interstitial lung disease. That was the first thing I noticed. And, now it's 10 years, right? 10 years since that. And now we have gone back and looked at scans. One of my favorite things to do is to read out with a fellow or resident and to look at the earliest scan in a patient that we know has ILD. And not even just that chest CT, to go look at that abdominal CT for a renal stone and see if you can see any findings at the lung bases and see what the earliest form of fibrotic lung disease is. And, I will tell you, as we've gotten better at this, and we're still learning, and we're still trying to get all the radiologists on board with this, we really try to identify those first imaging findings that may get us to say there is subclinical fibrosis here. And so that's kind of been the journey with ILD, first to really get good at diagnosing interstitial lung disease, and now to identify subclinical fibrosis by imaging.
How you mentioned going back and looking at all the imaging, including even abdominal CTs. How often would you say, you might not have a number, but how often would you say that you're seeing these things, the first representations of these interstitial lung disease show up on non-dedicated chest imaging?
I would say a lot.
A lot.
Yeah, I would say, like, there are times I've had to even educate some of the body people in our own Medical Center to be like, you guys need to comment on this because this is a real finding. There are architectural changes here that may impact this patient in a couple of years, and we want to get them to POEM to potentially get PFTs and look for restrictive physiology. And so I would say we see findings very frequently on scans that aren't dedicated chest CTs.
Yeah, no, that's really interesting. And then from a like a pulmonologist perspective, I also look at the chest imaging as well. At least compared to like what I'm used to seeing some of these end stage ILDs, how subtle can these changes be? Or am I looking for something, or should it be something that's, if you're used to looking at some of these chest CTs, should be obvious for you?
Yeah, I mean, that's where we get into the weeds a little bit and where I get made fun of by some of the people in my section because I'm overcalling ILA. I mean, it's just the reality. Like, we see subpleural opacities when a patient is laying on their back on a hard CT scanner. And it's when are you going to make that call to say, hey, this is interstitial lung abnormality? And I think really honing in on those imaging findings of reticulation, traction, obviously honeycombing, to be able to say, no, this is true fibrotic lung disease or subclinical fibrosis. But it can be very, very, very difficult. And we certainly don't want to be overcalling interstitial lung disease or subclinical fibrosis, and it's a fine line. And I would tell you, those of us who are trained in thoracic radiology, we even have difficulty with it too. So I would tell you, it is still very difficult to do.
Yeah, no, that's really helpful. So let's say we have this patient and the body radiology people find what they think is an ILA, and the recommendation is to get them into pulmonary. Anna, how from a clinical side, how are we drawing the line between ILAs and ILD? So what would you say that difference?
Yeah, it's a hard decision sometimes. And so we, in this document we recently published, we try to have the term ILA be kind of more broadly inclusive and so less specific. And a lot of individuals with ILA will not progress to true fibrotic lung disease. And so we try to identify features in individuals with ILA that would make someone, a pulmonologist or even a radiologist, say that this is not just an abnormality, this is early disease. And so we actually, as a committee, proposed a definition of ILD, individuals with ILA, and we considered individuals with symptoms that can be attributed to ILD as having a disease rather than an abnormality, as well as physiologic abnormalities, any decrements below normal in FVC, TLC, or DLCO. And importantly, there's a large body of data and imaging findings of fibrosis, and those individuals who have an ILA with obvious fibrosis as having really high mortality rates. And so importantly in this document, we said that individuals who have honeycombing or traction bronchiectasis in the context of reticulation that involves 5% of more of the total lung volume should be considered as having an ILD rather than just an abnormality. That would usually be an early ILD if those findings are mild and subtle, but those abnormalities have been shown to be associated with higher mortality rates. And as well as progression of ILAs over serial CT scan, or progression or decrements or decline in PFTs over time would also be considered a disease rather than just an abnormality. And then in individuals who happen to have a lung biopsy for, let's say, a nodule resection, and if you can find an ILD, presence of fibrosis of a fibrotic pattern on biopsy, that should also be called an ILD rather than an ILA.
So I liken a lot of this definition. You're talking about you have symptoms that can be attributed to the interstitial lung process here. For the parallel in the critical care world is ARDS. You think that it's not related to cardiogenic pulmonary edema. What would you recommend to clinicians who are seeing these patients in clinic? How far should they go to evaluate other causes of dyspnea, for example? Before you're saying that this is going to be attributed to ILA? Should I be getting an echocardiogram, even if their PFT is normal, they don't have orthopnea, or how far should I be going?
Sure, absolutely. I think this is where the art of medicine comes in, right? And so if I'm seeing a patient who's coming in with shortness of breath for an evaluation, for a pulmonary evaluation, I'm looking at their CT scan and I'm looking at the extent of abnormalities on their CT scans. And can that extent of abnormality truly explain that dyspnea, or is there something else that we're missing? And so, if it doesn't seem like their combination of their pulmonary function and their CT scan, it really explains the extent of their shortness of breath, then I am pursuing other things like an echo, even occasionally a CPET or cardiopulmonary exercise test. There's also some advanced imaging modalities that could be considered in those settings to try to really figure out why someone is short of breath.
My favorite test from pulmonary boards is CPET. Absolutely.
Early bird registration for ATS 2026 in Orlando is now open. Register now and save. Members get a discount, so become an ATS member or renew your membership to take advantage of the savings. Visit conference.thoracic.org today.
We've talked a little bit about, ILAs and ILDs and when to call it. Joe, I'm curious, are there features of a patient's thoracic imaging that may make you say, where's the line between calling something an ILA versus ILD from a radiology perspective?
Well, this is still a moving target for all of us. And I would tell you, initially it was all about if the patient had imaging findings, if they were actually symptomatic. And so that's when we would shift gears from ILA to ILD. And I promise you, we have patients in our lung cancer screening group that have honeycombing that we are saying ILA, because I'm calling the clinician like, no, they're asymptomatic. And we're like, that's not even possible. And we're watching them progress over their annual lung cancer screen, right? It's a great patient population to watch true interstitial lung disease progress. And so, when I see the features for me that slam dunk it are honeycombing and traction. Really, only restrictive physiology is going to give you that appearance architecturally within the lung. Reticulation is a little bit of a slippery slope, right? We've seen other things cause reticulation. But when I see those other two features, I really start to kind of, in my mind, push this from ILA to ILD. Obviously, there's a lot of stuff that goes into an ILD diagnosis, and that's a very important diagnosis to make. But for me, radiographically, those are the things I think about with true fibrosis.
Yeah, that's really interesting. I think both of you have kind of mentioned this following over time and who's going to progress. I think either Anna or Joe, what kind of patients are we looking for as far as those patients who you're concerned about their ILA progressing? Because, and please correct me if I'm wrong, my understanding is that some of these patients ILA will not progress and some of them will actually get better over time too, at least radiographically.
Sure, I can start and then Joe can maybe add to it. So back in the Fleischner document, they define subcategories of ILAs, and those subcategories are there because they're associated with different risks of progression. So there's a non-fibrotic ILA, so that's pure ground glass, and even just reticulation, as Joe mentioned, it's non-specific. So those are considered non-fibrotic ILAs, and in those cases, they're less likely to progress. But individuals who have subpleural abnormalities, so subpleural non-fibrotic ILAs have a higher risk of progression, and then that presence of frank fibrosis, as Joe mentioned, it's the same in my sphere. It's presence of traction bronchiectasis or honeycombing, or occasionally, you may not be frank traction bronchiectasis, but even more subtle traction bronchiolectasis is associated with higher risk of progression. And so those are the individuals that I'm watching more closely and monitoring over time with serial PLT serial imaging.
Yeah, the only thing I would just add to that is, specifically agree with Anna on the architectural findings, of course. In addition to that, anything clinically that our clinicians can give us that is even a whiff of this could be like true ILD in a connective tissue disease person, or anybody with any type of history, familial history, that's when I start to really start thinking these findings are more likely going to progress and probably represent true fibrotic lung disease.
Yeah, no, that's really interesting. And kind of building off of this, you said, talk about history and connective tissue disease, patients with familial histories, and you mentioned lung cancer screening. Are there, it seems like everybody gets some sort of cross-sectional imaging at some point in their life, but a lot of these patients actually don't. We see a select subset of patients here in the hospital. Are there patients who should get screened, even if we don't know that they already have an ILA or otherwise?
Sure, yes. So in our document, we suggested screening for any first-degree relative of family of individuals who have familial pulmonary fibrosis, meaning those are individuals where there are 2 or more family members with any type of pulmonary fibrosis in a family. And so we know that those individuals, their first-degree relatives, have roughly 1 in 4 risk of having at least an ILA, if not early ILD. And so we suggested screening in that patient population once they reach the age of 50. There was some discussion about also screening in individual first-degree relatives of individuals with IPF and just sporadic IPF. However, there's data that suggests that the risk is similar in sporadic and familial pulmonary fibrosis in terms of the genetic risk to their relatives, but the data in the sporadic patient population is just much more sparse. There aren't as many studies, and so we've thought there would be a large burden of potential screening population. And so I think in those cases, it should be an individual discussion. And if there's additional PFT abnormalities or any symptoms, then I would consider screening also in that patient population. We also suggested screening in patients with connective tissue disease that are associated with ILD. So those are individuals with scleroderma, rheumatoid arthritis, myositis, mixed connective tissue disease. I'm not sure if I'm missing anything else. And then lung cancer screening obviously is a large patient population and smokers in general. And so in that patient population, I think there should be a concerted effort towards reporting ILAs on those lung cancer screening CT scans. We're still seeing a lot of radiologists not formally reporting ILAs when they're present. And so if there's someone's undergoing a CT scan, it should at least be evaluated for the presence of an ILA.
You know, Joe, there's so many different flavors of CT scans. It's so easy for me to say in clinic to one of the fellows, oh, we can go ahead and screen them for an ILA. What would you recommend to us on the kind of ordering side, or what kind of CTs chests are adequate, or what would be the best possible? Because I know we've talked about low dose lung cancer screening CTs. There's normal CT chests. We do a lot of high res or like multiple position where the patient gets sent through the scanner multiple times, is supine and prone, inspiratory, expiratory films. What would be best if we're talking about this kind of screening population?
Yeah, I mean, the first thing I would tell you is non-contrast. No thoracic radiologist wants to have contrast, right? We start lighting up pulmonary vessels and lymphatics, and then I'm like, is that reticulation or is that contrast? So first, non-contrast. So if you have a patient that you're suspicious, maybe they went to the ED and got a PE study, that's probably not going to be enough for us to be able to say, in particular, ILA. So they're going to need a non-contrast chest CT. Outside of that, honestly, the low-dose lung cancer screening images are really good. There's enough contrast, there's enough attenuation difference between the pulmonary parenchyma and pulmonary fibrosis that we can see those imaging findings. So that is a pretty good study. If I was going to shift gears and say, hey, I'm on an abdominal CT, which is non-contrast, is this ILA? Then I would just punt right to what we have as an interstitial lung disease protocol CT. And, for that, it's exactly what you said. First of all, I want thin section imaging. So non-contrast, thin section imaging, they should be at least less than 1.25 images. I don't really want to see greater than 1.25 because you're going to miss ILA. And then, when we get these subpleural opacities laying on their back, it's great to get prone imaging in addition to supine imaging to see if those things resolve and see if that actually wasn't even ILA. And then also the expiratory imaging can be very helpful to look for airway-centric fibrosis like HP or some other airway-centric disease. And so that protocol is kind of built into many of these academic centers for interstitial lung disease. And I would tell you, if you don't have a really good non-contrast chest CT, which is good enough, I think, to address these questions, then I would move to an ILD protocol CT.
Let's say we've gotten to the point where we are ILA. We said they have a radiologic abnormality that suggests that they have ILA, but they don't have symptoms attributed to that. How, Anna, when you see this patient in clinic, how are you managing them? What kind of things are you going to be looking for, and how are you counseling these patients?
Yeah, absolutely. So my approach is to risk stratify those patients with ILA and to figure out if at what risk of progression they are. And so that's where all those other clinical factors come in. Like, is there a family history? Is there a presence, signs or symptoms of connective tissue disease? Are there other risk factors like smoking or reflux or other things that are associated with pulmonary fibrosis? So I'm evaluating the patient as I would any patient potentially with ILD, just to look for that history, that clinical history, considering looking for autoimmune serologies in select patients depending on their risk, and then doing a lot of teaching, counseling on the genetic risk, on the exposure modification. Obviously, if they're smoking, they should quit smoking. We're looking for occupational exposures and risk factors for progression in terms of that. And then I'm mainly telling patients if they have subtle early abnormalities that they should not be ignored, that they need follow-up. And, as Joe was saying, you can often look back 5-10 years and see people had subtle abnormalities on their CT scans. And then you're seeing them in clinic 5-10 years later and counseling them about oxygen because they have end-stage fibrosis. And that's really frustrating when something could have been done to intervene earlier. And so I'm telling patients, come back and see me in a year, get a breathing test. They should get a baseline breathing test and they should get a follow-up breathing test just so we can trend it. Don't forget to follow up. Come back once a year to see me. If any new symptoms develop, come back sooner. And then imaging depends on kind of where they lie along that ILD risk. We said in our document, follow-up imaging in 2 to 3 years for ILAs, but if they have more suggestion of a fibrotic process, then I might do a sooner CT scan, like at a year.
I was talking to some of my colleagues as we were preparing for this episode, and you mentioned in a couple of times that there's a good review published by you in the Blue Journal in July of 2025 called "The Approach to the Evaluation and Management of Interstitial Lung Abnormalities: An Official American Thoracic Society Clinical Statement." And in that, as you mentioned, that there's you screen PFT high risk every 6 to 12 months, low risk every 2 to 3 years. How did you and the committee come up with some of these different time frames for these different screenings?
So this is an evidence-based document. So there was a large literature search and an evidence synthesis that guided our suggestions. And these are all suggestions. And so they need to be individualized to practice settings and individual patients. But so there was a committee of 40 individuals from across the globe. And so the suggestion for follow-up was based on studies in certain populations, and for example, in a health screening cohort out of Korea, where they do routine kind of CT scans for general health screening. And they had a long follow-up of individuals who underwent serial CT scans for health screening. And they looked at time to progression in that population. And they found that time to radiologic progression in ILAs was actually, median time was about 3 years, but median time to progression to UIP was closer to 10 years. And so it was really based on that data showing that an ILA is something that can progress very slowly. Now, in individuals with a family history and with some more fibrotic features, that time to progression is shorter. And so in those individuals, that's why we suggested doing a shorter interval for follow-up.
Interesting. And Joe, from your perspective, radiology can sometimes be this time machine as you get to review all these different imaging studies over time. What is your, I guess, gut reaction to this time frame? Does it seem like a reasonable time frame from what you're seeing in your experience or otherwise?
Yeah, I think that's pretty accurate. It's great because in the lung cancer screening group, which is certainly one set of ILA and interstitial lung disease, we're able to kind of watch these features every year, right? So you really get a perspective for that. Also kind of looking at the different classes of patients that come to our ILD clinic and going back at looking at the images, some of these architectural features are totally unchanged, right? And then some of them progress pretty rapidly. And so I think the evidence-based approach is really appreciated for following these patients.
Yeah, that makes a lot of sense. I have one more question, I think, for Anna before I want to get both of your all's kind of closing thoughts on this. And you had mentioned, talking about like genetic risk. Are these Are there patients or are there situations in which you would recommend genetic testing for different types of ILD variants that we have known gene associations?
It's hard because genetic testing is not yet broadly and widely available. So we know that there are variants, for example, in the MUC5B. It's a common variant that's strongly associated with IPF and with ILAs, actually. There are also multiple variants in genes that are associated with telomere length and telomere dysfunction that are a strong risk factor, especially for familial pulmonary fibrosis. And so in individuals who have a family history, who have FPF, who have diagnosed ILD, that you could consider referral to genetics if that's available, but otherwise we're not routinely testing those individuals for specific mutations or variants because there's also a lot of unknown. There's a great study actually out of group at Columbia University that looked at the FPF population and in individuals who have a known family history. They found that in well over more than half of individuals, they when they did whole genome sequencing, they couldn't identify a specific variant that was related to their lung disease. So there's still a lot of unknown about the genetics. Telomere length in itself could be considered testing, and a lot of centers are measuring telomere length in individuals, some individuals with ILA and individuals with ILD. But again, that also depends on availability and cost of that test because it's not widely covered by insurance.
That makes a lot of sense. This has been really enlightening to me and really educational, and I hope it's for the listeners as well. I'd like to just see if there's anything else that you'd like to leave our listeners with. I guess I'll start with Joe first, and then we can close out with Anna.
Yeah, I mean, I think the biggest thing is we've learned so much about interstitial lung disease over the last 10 years. We've gotten really good as a group of thoracic radiologists. We've tried to impress upon the people in radiology who trained before 2014 to really explain to them that this diagnosis is very, very, very important because there's treatments out there that didn't exist. Now we're kind of shifting gears to kind of really pick out who are the people that have these subclinical features, right? Radiology is the gatekeeper, for better or for worse. Sometimes I say for worse, but we're the gatekeeper for identifying these patients and getting them to pulmonology. So it's really, really important to identify these imaging features and be able to say, hey, this is ILA, let's get them to pulm, and then we can see if they're actually going to progress.
That was great, Joe. Anna, what about you?
In the same vein as what Joe mentioned, just please don't ignore findings. This is what keeps me up at night, is when I see patients coming in with end-stage disease and we could have intervened earlier. Not every patient with an imaging abnormality or even early fibrosis necessarily needs treatment, but properly diagnosing them and monitoring them over time to decide when it is appropriate to intervene and to treat is the most important thing that I look for in my practice.
Yeah, I think one of the important things for our listeners, as we already referenced, I think we can link in our show notes, is to go to the statement that was put out by Anna and colleagues, published in the Blue Journal. But I would like to thank everybody and for joining us for today's ATS Breathe Easy episode. Please subscribe and share this episode with your colleagues. Put it on your calendar. I think early registration for the ATS conference in Orlando in May has already opened. Go to conference.thoracic.org today. Members get a discount on the conference registration, so become a member to renew your membership and take advantage of the savings. That's a good reminder for myself too. And we will see you next time. Thank you, Anna. Thank you, Joe.
Thank you all.
Thank you.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.